Good day, Miss. My name is Ezekiel Haney R. Ong from BSN2 Mercer, and today I am going to do the procedure called nasogastric tube feeding or NGT. So the definition, nasogastric tube feeding is the instillation of specially prepared nutrients into the stomach through a nasogastric tube. For the assessment, assess client's need for internal tube feedings, impaired swallowing, decreased level of consciousness, head and neck surgery, facial trauma, surgeries of upper alimentary canal, identify clients who need tube feeding before they become nutritionally depleted, auscultate for bowel sounds before feeding. Absent bowel sounds may indicate decreased ability of gastrointestinal tract to digest or absorb nutrients. Obtain baseline weight and laboratory values. Assess client for fluid volume excess or deficit, electrolyte abnormalities, and metabolic abnormalities such as hypoglycemia. Internal feeding is to restore or maintain a client's nutritional status, provides objective data to measure effectiveness of feedings. Verify physician's order for formula, rate, route and frequency, laboratory data and bedside assessments, such as finger stick blood glucose measurement, are also ordered by the physician. Tube feedings, laboratory tests, and bedside tests must be ordered by the physician. First procedure, explain the procedure to the patient. Discussion and explanation help allay anxiety, encourage patient cooperation, and prepare the patient for what to expect. Second procedure, perform hand hygiene. For hand hygiene, determines the spread of microorganisms. Third, prepare feeding container to administer formula. Have tube feeding at room temperature. Cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Connect tubing to container as needed or prepare ready to hang container. Tubing must be free of contamination to prevent bacterial growth. Next, shake formula container well and fill container and tubing with formula. Filling the tubing with formula prevents excess air from entering the GI tract. Fourth procedure, place client in high Fowler's position or elevated head of bed 30 degrees. For elevated head, helps prevent aspiration. Determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated contents to stomach unless the volume exceeds to over 150 ml. Presence of gastric secretions indicates that the distal end of the tube is in the stomach. Residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more, remaining in the client's stomach. Measure pH of aspirated GI contents. Fasting gastric pH is usually equal to or less than 4. It is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Observe the aspirate's appearance. Gastric fluid is usually cloudy and grassy green, or tan off-white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearer than gastric contents. Consider the results from pH testing and the aspirate's appearance together. An aspirate with a low pH and a typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden-colored aspirate with a high pH indicates a high probability of intestinal placement. Initiate feeding. Bolus or interment feeding. Pinch proximal end of the feeding tube. This prevents air from entering client's stomach. Remove plunger from syringe and attach barrel of syringe to end of tube. Fill syringe with measured amount of formula. Release tube and hold syringe high enough to allow it to empty gradually by gravity. Refill, Repeat until prescribed amount has been delivered to the client. Gradual emptying of the tube feeding by gravity from syringe or feeding bag reduces risk of abdominal discomfort, vomiting or diarrhea induced by bolus or too rapid infusion of tube feedings. If feeding bag is used, hang feeding bag on an IV pole. Fill bag with prescribed amount of formula and allow bag to empty gradually over at least 30 minutes. Continuous drip method. Hang IV bag and tubing on IV pole. Continuous feeding method is designed to deliver prescribed hourly rate of feeding. This method reduces risk of abdominal discomfort. Clients who receive continuous drip feeding should have residuals checked every 4 hours and tube placement verified. Connect distal end of tubing to the proximal end of the feeding tube. Connect tubing through infusion pump and set rate. Advance tube feeding gradually. Tube feeding should be advanced gradually to prevent diarrhea and gastric intolerance formula. When tube feedings are not being administered, cap or clamp the proximal end of the feeding tube. This prevents air from entering stomach between feedings. Administer water via feeding tube as ordered with diluted formula. Provides client with source of water to help maintain fluid and electrolyte balance. Step number 10. Rinse bag and tubing with warm water whenever feedings are interrupted. Rinsing bag and tubing with warm water clears old tube feedings and reduces bacterial growth. Next, measure amount of aspirate residual every 4 hours. Evaluates tolerance of tube feeding. Step number 12. Monitor finger stick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. Alert nurse to client's tolerance of glucose. Next, monitor intake and output every 24 hours. Intake and output are indications of fluid balance or fluid volume excess or deficit. Wait client daily until maximum administration rate is reached and maintained for 24 hours. Then weigh client 3 times per week. Weight gain is an indicator of improved nutritional status. However, sudden gain of more than 2 pounds in 24 hours usually indicates fluid retention. Step 15. Observe the return of normal laboratory values. Improving laboratory values, the albumin, transferrin, and pre-albumin indicate an improved nutritional status. For evaluation, patient tolerates feeding well, and weight is maintained or increased. Appropriate residual is obtained from aspiration of stomach content. Patient complies with feeding procedure. Intake and output balance is maintained. Lastly, nasogastric tube functions efficiently and remains patent or patent. That is all. Thank you.